What if I told you that one of the most dangerous complications of pregnancy can develop silently, sometimes without a single symptom until it's too late? Would you be able to recognize it in time? Hi everyone, welcome to Mnemonic. Today we are talking about preeclampsia, a condition that not only threatens the life of the mother, but can also have devastating consequences for the baby. Let's break down what it is, why it happens, and how we detect and manage this condition. So, what exactly is preeclampsia? Preeclampsia is a hypertensive disorder in pregnancy marked by a high blood pressure reading. Specifically, a reading of 140 over 90 or higher is diagnostic. This condition typically develops after 20 weeks of gestation and is also characterized by the presence of proteins in the urine, a condition known as proteinuria. This proteinuria is one of the key features used to diagnose preeclampsia. Before we dive deeper into the topic of preeclampsia, let's first take a quick look at the different types of hypertension that can occur during pregnancy. We start with chronic hypertension. This refers to a high blood pressure, specifically readings of 140 or 90 or higher, that is present before 20 weeks of pregnancy. Next, we have gestational hypertension. This also presents with blood pressure readings of 140 over 90 or higher. But unlike chronic hypertension, it occurs after 20 weeks of gestation. Now, let's focus on preeclampsia, which is the main topic for today's discussion. Like gestational hypertension, preeclampsia also involves a blood pressure reading of 140 over 90 or higher and develops after 20 weeks of pregnancy. But here's the difference. What sets preeclampsia apart from gestational hypertension is the presence of proteinuria, that is, excess protein in the urine. In gestational hypertension, there is no proteinuria. So while both conditions share similar blood pressure readings and timing, the presence of proteinuria is what distinguishes preeclampsia. Now let's talk about risk factors for preeclampsia. Several factors can increase the likelihood of developing this condition. Nulliparity. This refers to women who have never been pregnant before. Multifetal gestation. Women carrying twins or more have a greater risk of developing preeclampsia. Family history or personal history. If you've had preeclampsia in the previous pregnancy, or if there is a family history of the condition, you are much more likely to develop it in subsequent pregnancies. Increasing maternal age. Women aged 40 and older are at an increased risk, although some studies suggest this age to be as low as 35 as a risk factor. Obesity. Women with a body mass index of over 30 are at greater risk of developing preeclampsia during pregnancy. Now I want to take your attention to the signs and symptoms of preeclampsia that healthcare providers should look out for. Women with severe preeclampsia may report several symptoms. These symptoms include headaches. These can be severe and persistent. Visual disturbances such as blurred vision can also be a warning sign. Edema. Now, this edema is just not limited to the legs. Swelling can also affect the hands and face. Interestingly, many women may be asymptomatic, meaning that the condition could be detected during routine screenings before symptoms even appear. Other severe symptoms to be aware of include abdominal pain in the right upper quadrant, which could indicate the development of HELLP syndrome. We will dive deeper into HELLP syndrome later in the video. Fetal distress. In some cases, the baby might show signs of distress, such as fetal growth restriction. It is important to note, guys, that fetal growth restriction could be indicated by the uterus being smaller than expected for the gestational age. Reduced fetal movement. This is another concerning sign that healthcare providers should monitor closely. Now, let's move to the investigations needed to diagnose preeclampsia. The most important test is, of course, blood pressure monitoring. To confirm the diagnosis, we need at least two separate readings taken at least 4 hours apart, showing a blood pressure reading of 140 or 90 or higher. Next, we need a urine analysis to check for the presence of protein in the urine, as proteinuria is the key diagnostic feature of preeclampsia. In addition to these, blood tests can reveal other important abnormalities. These may include low hemoglobin, which of course indicates anemia, low platelet count, which may suggest a more severe form of the condition, abnormal liver function tests. So often these patients have an elevated serum level of ALT and AST. As the disease progresses, rising creatinine levels can also be seen, indicating impaired kidney function. Fetal monitoring is a crucial part of assessing the health of the baby in cases of preeclampsia. Several tests can provide important information about fetal well-being. For example, fetal ultrasound. This helps measure the baby's size and detect signs of intrauterine growth restriction. It's also used to assess the amniotic fluid volume, which can give us additional clues about fetal health. Also, guys, cardiotogography. This technique is used to monitor both the fetal heart rate and uterine contractions simultaneously. The process involves placing an ultrasound transducer on the mother's womb, allowing us to track these vital measurements in real time. Another unique investigation is umbilical artery Doppler. So, what is this umbilical artery Doppler? The clue is in the name. So, this investigation measures the velocity of blood flow in the umbilical artery, and this can help assess the baby's oxygen and nutrient supply. The reason why this information is so valuable, guys, is because it can guide clinicians in making informed decisions about delivery timing and management. So let's now look at how we should treat patients presenting with preeclampsia. First and foremost, guys, in an emergency setting, the ABCDE assessment is crucial. This means we need to assess and address any abnormalities right away, stabilizing the patient and monitoring signs closely. In cases of severe preeclampsia progressing to eclampsia, we might need to take additional steps. For example, we need to make sure the patient is catheterized so that we can monitor urine output closely. We should also initiate fluid restriction measures to manage any fluid overload. When it comes to antihypertensive treatment, one of the most effective and safest options is labetalol, a beta blocker which is commonly used in preeclampsia. It can be administered either intravenously or orally. If the patient is asthmatic or allergic to beta blockers, oral nifedipine, a calcium channel blocker, is the treatment of choice. Another commonly used IV antihypertensive in these patients is hydralazine. One of the most dangerous complications of preeclampsia is progression to eclampsia, which is characterized by seizures. In cases of severe preeclampsia, IV magnesium sulfate is both used as a prophylactic treatment to prevent seizures and a therapeutic option if seizures do occur. However, the definitive cure for preeclampsia is the delivery of the child. The timing of delivery, although, can depend on a variety of factors, including the results of the cardiotogography to assess fetal well-being, and any abnormalities in the umbilical artery Doppler also need to be noted. After gathering all this information, the clinician will decide if delivery is the best option. If the baby is less than 34 weeks of gestation, steroids such as dexamethasone should be given to promote lung maturity. If delivery is necessary, a C-section is typically the preferred method due to the gestational age of the child. For babies over 34 weeks of gestation, a normal vaginal delivery can actually be possible. However, if there are any other complications, either maternal or fetal, then once again, C-section may still be required. Now, let's discuss the complications associated with preeclampsia in a bit more detail. One of the most serious and potentially life-threatening complications is HELP syndrome. This is a condition characterized by three key features that every doctor should look out for. Number one, hemolysis. Hemolysis, we all know, this is a breakdown of red blood cells. Second is elevated liver enzymes. Specifically, I'm talking about AST and ALT levels, which often rise above 70. Thrombocytopenia, a significant drop in platelet count can be seen in these patients. HELP syndrome often presents with abdominal pain, particularly in the right upper quadrant of the stomach. That is a crucial symptom to watch out for, guys. So always remember to ask patients if they're experiencing any abdominal discomfort. As we know, this can often be a warning sign. The textbook definition of eclampsia is new onset generalized tonic-clonic seizure in women with preeclampsia not attributable to other causes. So, Guys, let's dissect this definition. New onset, so we need to ensure the patient does not have any pre-existing seizure disorders which might be the cause of this seizure. Generalized tonic-clonic. Generalized refers to involving both hemispheres of the brain. Tonic refers to stiffening of the muscles. Clonic refers to rhythmic jerking in a woman with preeclampsia. So the pregnant female needs to already have a diagnosis of preeclampsia for us to class this seizure as eclampsia. Finally, not attributable to other causes, meaning that before a physician should diagnose this female with eclampsia, they should rule out any other causes of the seizure. So, for example, brain tumors, strokes, hypoglycemia, meningitis, encephalitis, all these conditions need to be ruled out before we confirmatively say this seizure has been caused by eclampsia. As we discussed earlier, this is a medical emergency that requires immediate intervention. These patients are typically admitted to the ICU and need timely administration of the IV magnesium sulfate in order to control these seizures. We have already discussed regarding fetal growth restriction, which is also an important condition to monitor for, typically through the use of an ultrasound. Another serious complication is placental abruption, where the placenta prematurely separates from the wall of the uterus. This can lead to massive hemorrhage and hemodynamic instability in the mother, which does require urgent hospital admission and close monitoring of vital signs. Placental abruption usually presents with abdominal pain and vaginal bleeding after 20 weeks of gestation. So guys, I've created a useful mnemonic for you all to remember preeclampsia in your clinical practice. This mnemonic will help you recall both the clinical manifestations as well as the treatment of preeclampsia when examining pregnant patients. So, the mnemonic for preeclampsia is preeclampsia, with each letter representing something important. So, let's get started. P stands for proteinuria, the presence of protein in the urine, which is a key diagnostic feature. R stands for renal disease, which indicates the severity and progression of the disease. E stands for elevated liver enzymes. So, if AST and ALT are elevated, this can be indicative of HELLP syndrome, which is a medical emergency. E stands for elevated blood pressure. So a reading of 140 or 90 or higher, which is the primary diagnostic criteria for preeclampsia. C stands for creatinine. A rising creatinine level is a marker of deteriorating kidney function. Then we come on to L. L here stands for low platelets, thrombocytopenia, which is another indicator of HELLP syndrome. So guys, P to L in preeclampsia highlights the clinical manifestations of the condition. Now let's move on to ampsia, which refers to the management of preeclampsia. So here, A stands for antihypertensives. As we discussed earlier, common options include labetalol, which can be administered orally or IV, nifedipine, which is given orally, and we also have hydralazine as an option in severe cases. Now, as we discussed earlier, MgSO4 is used for seizure prophylaxis. So, M here stands for MgSO4, for P for prophylaxis, of S for seizures. I stands for induction of labor. Since delivery is the definitive treatment for preeclampsia, inducing labor might be necessary, especially if condition worsens. A stands for admission. Given the potential for severe complications, patients presenting with preeclampsia should be admitted to the hospital for close monitoring and care. So I hope you guys will not forget this preeclampsia mnemonic. It can really help you remember both the clinical features and the management strategies for this condition, ensuring that you act quickly and appropriately in your clinical practice. Guys, if this video helps you understand preeclampsia better, give it a like so others can find it too. Subscribe and hit the bell for more easy to follow medical explanations with mnemonics. And now I will leave you with this one question. If the placenta is gone after birth, why can preeclampsia still appear or even get worse days or weeks after childbirth? Please drop a comment below to let me know what you think or with any other questions, feedback or suggestions for future videos.